Hi, everybody. Today's lecture is going to be on etiologies. Etiology means cause. So we're going to look at the neurologic etiologies of speech, language, and cognitive disorders. And let me bring up my screen here, and we'll just talk about where we're going with this for a moment. There we are. I do see my picture there, so hopefully it comes across. So there, of course, when we get to swallowing next semester, there are etiologies other than neurologic. And so this is, you'll have this exact same lecture, although I won't need to record it again because you've already got it, but just a few additional causes of swallowing disorders, but we'll get there. So this is mostly going to cover the two courses. You'll be looking at the most common etiologies in most detail. There are a lot of possible etiologies. I'll get to one which will surprise you. It surprised me. But I've never seen a patient with that particular surprising etiology. So we're gonna spend our time on the things that you're gonna see the most. That's where we're going. Okay, so now let me start with this. And this is two slides. But before I get it, what do we care about etiologies? Let's just talk about that for a moment. What's so important about etiologies? Etiologies are really important because when you do your assessment and you get to your speech language pathology diagnosis, one of the first things you're going to do after you get all that information and decide what it means is you're going to determine a prognosis. Are they going to get better? Are they going to stay the same? Or are they going to get worse? And then you're going to develop an appropriate treatment plan that goes with that prognosis. And it all should fit together and make sense, but it starts with the medical background information about that person, because that's actually how you're going to determine the prognosis, the chances for them to improve or perhaps not to improve, or perhaps even to get worse. We need to know that. And so we're just going to go through the etiologies today, with emphasizing certain ones more than others. And there are 57 slides, I believe. That's too many for one lecture, at least for me, probably for you as well. So I'm actually dividing it into two segments, 41 slides for this one this week, and then there will be about 16 slides, which will go quite quickly next week. So we'll have some extra time next week, and what we're going to fill in with is some information about where you get this information when you go see your patient. Where are you going to find the information that gives a medical background? How are you going to determine what's relevant, what's important, what's not important, and how are you going to analyze it, and then how are you going to write it up? So next week, we'll look at the overall format of an evaluation, a comprehensive evaluation for this category of disorders. And we'll go through, over the semester, we'll actually fill it all in with different sections so that you see how it comes together. And the first part is background. It's really medical background, but there's some things in it that are not particularly medical as well, so I just call it background. And so next week, we'll learn how to write that. Also, because it's the second section, and it's pretty easy to learn how to write it, we're going to learn how to write a section on prior level of function before they got sick, in terms of communication and also swallowing, but we'll address that next semester. And that's very important because, generally speaking, not everybody comes into the hospital with a new stroke or something in a completely functional condition as far as their prior level of function goes. Some of them had some big problems before. And we need to know about the prior level of function, because obviously your prognosis is generally not going to be to make them better than they were before they got the new illness, if that makes sense. Okay, now we're ready for the next two slides. And this is a table showing which of the categories that we're going to go through are localizing. Meaning, what's a localizing neurologic disorder? It's one that points to a particular part of the nervous system where the problem is, where usually the damage. So you could say, well, somebody had a stroke in Broca's area. The fact that they have that Broca's aphasia is localizing. It tells you where in the brain the stroke has occurred. You can look at a CT scan too, but basically, between you and a neurologist, a localization of damage is often known before any tests are done, just based upon observing and assessing the patient in a bedside evaluation. So that's what a localizing is. Now, some things are not localizing. Let's say, for example, alcohol. Now, people who drink a lot eventually develop a cognitive issue. It's non-localizing. You can't tell where in the brain. It's just like kind of all over both sides. The first one here, you might have heard of it, disturbances of cerebral spinal fluid production. It's basically hydrocephalus. That's non-localizing. So we'll go through it. So some are non-localizing, some are localizing, and some are mixed. For example, traumatic brain injury. Generally, we think of that as being non-localizing because basically the person just has a cognitive disorder. They don't have a particular, that necessarily have a particular set of problems that point to a particular part of the brain. It's both sides of the brain are involved. But on the other hand, a gunshot wound also produces those same generalized effects. And in addition, some localized effects. So a person with a gunshot wound may have a hemiparesis or some of the things that you're studying right now as you've gone through the cranial nerves. So I thought it would be useful just to start our thinking about, is it localizing, non-localizing, or mixed, as we just look at the set of disorders we're going to go through. And I call them disorders, but I really mean neurologic diseases and injuries when I say disorders, and that's not quite good use of the terminology. I should be calling it neurologic diseases and injuries, and they fall into these categories. First, disturbances of cerebral spinal fluid production, circulation, and uptake, or hydrocephalus, as we will see, non-localizing. TIAs, transient ischemic attacks, which are sometimes thought of as precursors to a stroke. They are usually localizing. If they produce any signs at all, it's going to be something like a hemiparesis or a language problem or a loss of a visual field. Those are all localizing. CBA, same thing. That's a completed stroke. Intracranial neoplasms are mixed. Generally speaking, they may start off with a localizing sign wherever that cancer or tumor in the cranium is growing. That may produce a localized effect. But as the tumor or space-occupying lesion grows, it begins to put pressure in all directions, and the person gets confused. Confusion is a hallmark of a non-localizing disease or injury. So that's a mix. Same for non-viral infections, same for viral infections. There's our traumatic brain injury, which I mentioned. Generally, we think of it as non-localizing, but if there's especially if there's a penetrating wound, it can produce mixed signs. Then we get to degenerative diseases like Alzheimer's disease. Tends to be localizing. Alzheimer's disease is probably one that's involves both sides of the brain. We'll talk more about it. Demyelinating diseases, as multiple sclerosis would be the main one there, localizing. Metabolic diseases, like when your blood sugar is way off or something like that, you can lose consciousness from that. And but before that, you become confused and groggy, and that's non-localizing. Same thing with disorders related to substance abuse, alcohol abuse, drug abuse, whatever it might be. And then there's a set of disorders related to malnutrition, and those are all non-localizing. Okay, so moving on to our first specific set of slides here. We're going to look at the disturbances of cerebral spinal fluid production, circulation, and uptake. And disturbances of the circulation are overwhelmingly the most common type of disturbance of cerebral spinal fluid. I'm just going to call it processing, which would include production, circulation, and uptake. In other words, typically people who have a problem in this area don't have trouble producing the fluid in the brain. They don't have trouble getting rid of the fluid in the brain. They have trouble with it circulating through the ventricles of the brain, and it gets blocked at some particular drain. In order to understand this completely, you do need to know the anatomy of the ventricular system. And I do believe you studied it before in your anatomy and physiology undergraduate course and or your neurology undergraduate course. I did put some slides, and I'm calling them supplemental slides on cerebral, on the ventricular system, and that's in this module. So you'll find that there. You might want to take a look at it, especially if you're a little confused about what I'm saying and where these drains are. They're very typical. But there is, I'm just going to quickly say it, but if you are unfamiliar with what I'm talking about right now in the next minute, go to those slides because they will show you. Typically, your fluid is formed in all four ventricles, and then it flows from the lateral ventricles, which are the deepest in the cerebral hemispheres, into the third ventricle, which is between the two halves of the thalamus, and then down through the aqueduct of Sylvius into the fourth ventricle, which is sandwiched between the pons and the cerebellum. And then it drains out of three drains into the subarachnoid space. And basically, in that subarachnoid space, the fluid just cushions the brain and the spinal cord from blows. In other words, your brain is kind of floating around. It's not just right up against the bone of the cranium. So that's protective. And it also provides a nice place for a nice environment for the brain to keep it moist and the pH balanced and all that sort of thing. So typically what happens is very often in traumatic brain injury, as would be a prime example, and the brain swells in a certain way, that aqueduct of Sylvius will block. It's a very small thing. I mean, it's about the size of a piece of pencil lead, and it's kind of long. It goes through the midbrain and then goes into the fourth ventricle, sandwiched between the cerebellum and the pons. And then from that one, there are three drains. So hardly anything can go wrong with drainage from the fourth ventricle into the subarachnoid space. But a lot can go wrong with the drain from the third ventricle. And when it does, what happens is the two lateral ventricles and the third continue to form their fluid, but it's got no place to go. So it starts enlarging those three ventricles and then pushing the cerebral hemispheres out against the skull. So it's very clear in a CT scan what's going on in that situation. The person, if they didn't have any problem before, will become confused as soon as their brain comes under pressure. And then when a CT scan is done to see if they can see the source of the confusion, sure enough, the lateral and third ventricle are enlarged, and the brain itself is squished, not a very scientific word, but squished up against the skull. So, and that would be referred to as hydrocephalus when that situation occurs. And it's a particular kind of hydrocephalus where there's excessive fluid in some place in the ventricular system or around the brain, or both. It's referred to as tension hydrocephalus because the pressure of the cerebral spinal fluid is elevated. How do they measure it? The easiest way is to put a little, well, not so little, it's a needle between about the third and fourth, or the fourth and fifth lumbar vertebrae, and to penetrate the subarachnoid space down a little lower than where the spinal cord actually ends. And they have a little device to measure the pressure. And it's supposed to be in a certain range. Here's the range down here, 150 to 180 millimeters of water. That's the way it's measured. And that would be normal range. But in tension hydrocephalus, they'll measure that pressure and it'll be high. So that is a very, very, very dangerous condition, because when somebody has tension hydrocephalus, it's more than likely an ongoing process that will result in death in about 24 hours unless the situation is corrected. And it will start with confusion. That's the first sign of tension hydrocephalus. If the person has no other issue, how would they get it if they didn't have any other issues? They could have a growing tumor in the midbrain, which puts pressure on that aqueduct of Sylvius. And then one day it's too much pressure and the fluid cannot get through it. And now they're going to get tension hydrocephalus, and it's going to involve those three ventricles. And it's first going to show up as confusion. If they let it go for 24 hours, it will result in reduced consciousness till they're unconscious, become completely unresponsive even to painful stimuli, and then death. So it's a very acute situation that must be normalized, or death will result. After somebody has hydrocephalus for a while, or if they have had shrinkage of the brain, either which way, they can have excessive fluid in the brain, which shows itself as larger ventricles and a greater space between the brain itself and the cranium. And then when they measure the pressure, they do the CT scan, see that situation, measure the pressure, it's in the normal range. That's referred to as normal pressure hydrocephalus. And it does result either from shrinkage of the brain due to some other problem, like a traumatic brain injury, kills neurons. And when you look at a CT scan a few weeks later, the brain is actually smaller if it's been a severe traumatic brain injury, or the degenerative process such as Alzheimer's disease, the brain actually shrinks and the person has hydrocephalus, but not a life-threatening hydrocephalus. Here I should have a hyphen here, not an equal sign, but you get the point. In either which way, the signs are going to be non-localizing, and it just tells you the brain itself on both sides is involved, and it does not specifically point to any other area more detailed than that. Okay, so now you know the two kinds of hydrocephalus, and you know that the tension hydrocephalus is the dangerous one that will kill, and the non-tension hydrocephalus or non-pressure hydrocephalus, it's also called, it does not. It's a chronic situation. So how does the diagnosis get made? Well, first of all, the history and physical, and on all of these slides, when we go through a different category of disorders, going to start there. Somebody comes into the ER, and what's the medical staff is going to notice, first of all, the person's confused or they have an altered level of consciousness. They could be unconscious. They have no localizing signs. And the first thing they're going to do after their history and physical is they're going to do computed tomography, a CT scan of the head. And that will show enlargement in a pattern that I have just described. Then they're also going to measure the pressure within the subarachnoid space. And that's called a lumbar puncture, what I described earlier. They can also do it with something called a ventriculostomy, which is basically they put a little burr hole through the cranium. I know it sounds awful, but it doesn't really cause any damage to the brain. And then they put a little, very tiny catheter through the brain tissue in a kind of a silent area of the parietal lobe where they're not going to cause any localized deficits. Like you wouldn't want to put it through Broca's area, for example, but they put it in a silent area where the brain doesn't seem to have specialization on either side. And then it gets down into the lateral ventricle, and then they can measure the pressure there. They can also relieve the pressure. So it's got a dual, that ventriculostomy has a dual function. They will measure the pressure, and then if it's elevated, they'll relieve the pressure. So it'll save a life until they figure out more. Okay, now a little more about causes. Brain edema, which is swelling, can and will result from most head trauma or traumatic brain injury. And then certain illnesses can also cause one or more of the ventricular drains to close, resulting in pressure hydrocephalus. And brain edema, that's just swelling, regardless of the cause, has a number of different things that are done for it. One would be hyperbaric oxygen therapy, hypothermia, cool the body, IV fluids using a hypertonic saline, in other words, a salty solution fed into the bloodstream. There are drugs such as mannitol. A ventriculostomy, which we mentioned before, is used to measure, but also to relieve the pressure. And also sometimes in very traumatic brain injury, they actually take off a large part of the skull. And they save it. I think they freeze it. I'm not sure, but they must freeze it. They wouldn't just put it in a drawer or something. They save that. And when the swelling of the brain goes down, they can put the skull back. And that sometimes you'll see people in rehab situations or long-term care situations where that skull piece is not put back for quite some time. And of course, they have to cover it over, and they need to make sure that the head is protected so that nothing, since there's part of the skull missing, it can be a large part, like the entire parietal bone or something like that. And then there's another kind of treatment you should know about for chronic pressure hydrocephalus, which is staying there. I mean, they could relieve it with a ventriculostomy, but that's kind of a temporary solution. For somebody who has a blockage and they're going to continue to have pressure hydrocephalus, they will the neurosurgeon will put in a drain into one of the lateral ventricles. Now they'll actually use that little burr hole I referred to, put the drain in, and then snake it under the skin, down through the neck, down into the body cavity, and down into the uh, cavity that surrounds the abdominal organs. And that is called a ventriculoperitoneal for ventricular system. Peritoneal cavity, that's your gut cavity. And it has a little pressure measurement device within the drain itself that when it gets over 180 millimeters of water, it opens up. So it's constantly on and off all day long to keep that pressure in that 150 to 180 range. And so that is a long-term management strategy for somebody who has chronic pressure hydrocephalus, and it brings the pressure down into the normal range. And so life is protected then. They last about 10 years roughly. And so you might have such a patient who's got a VP shunt, they're also called for short. And if you notice they become confused one day, you got to get to the doctor right away, because there's a very good chance that shunt has become blocked and is not operational anymore. And remember, 24 hours, that's about how long you have. Okay, there's another approach to the management of hydrocephalus would be rehabilitation, because people can have permanent brain damage from hydrocephalus, pressure hydrocephalus, and especially if it's not managed really quickly and successfully, that doesn't do much for your brain, and you could end up needing similar kind of rehab to what traumatic brain injured patients would receive. And then finally, just a reminder, non-pressure hydrocephalus, you can see it on the CT scan, but it does not require any treatment. All right, now, okay, transient ischemic attacks and strokes. We're going to do those, and then we will be kind of through the heavy duty part for today. But these will be some details. And I'm not sure how much you learned in your neurology course, but you'll learn as much as you need for right now to know how to look up the information and figure out your patients, especially if they're in the acute care hospital. Okay, so what is a transient ischemic attack, a TIA? Well, transient, transient means temporary, so we've got that part of the label figured out. And an attack is something that comes on suddenly. You got that part figured out. And now ischemia, you may not know ischemia yet. Ischemia is a local and temporary deficiency in blood supply due to obstruction of the circulation of the part. And it generally, it would be localizing. Now, you could have the process that I just described occur like way out here in the frontal lobes area, Brodmann's area 9, 10, and 11, where you do your executive functioning. Both sides of the brain seem to do both things. So you can actually have not just a TIA, but a big stroke, and there are no symptoms. So you wouldn't even know you had it. But if it were in Broca's area, for example, or if it were in one of the primary receiving areas for vision, for the somatosensory functions, for the motor strip, it's going to produce a localizing sign. So it is localizing or it's silent, one or the other. Now, what do I mean by localizing? It's in a specific part of the brain, and it shows a specific set of signs and symptoms which point to that part of the brain. That's a localizing neurologic injury or disease. So just again, to remind you, what's an ischemia? It doesn't mean there's brain damage. It just means there's been a deprivation of blood supply. It could be just very short term, and it causes the problem to emerge and be seen, the neurologic sign and symptom. And then the blood supply improves and they get over it. So now we're going to look at a little bit of formality in terms of the definition. A TIA is an ischemic event, means there is deprivation of blood supply involved in it, and the symptoms last less than 24 hours. The signs and symptoms last less than 24 hours. It is a warning sign. If your relative has a TIA, or you do, you're very young, I know, you want to get to the ER and have that diagnosed and figure out what's going on, because you shouldn't be having localizing neurologic signs, even if they're only 24 hours. I can't tell you how many people I've seen in the hospital who developed a hemiparesis or something like that, and it didn't go away in 24 hours. In fact, it didn't go away in 3 or 4 days, and finally they decide they better go to the hospital, but it's kind of late for some of the available treatments to be administered at that time. There is also this, I don't know, I should probably take this out of the slide because frankly, I haven't seen it in a medical chart for some time, but there is something that's sort of related to a TIA, and it's called a reversible ischemic neurologic deficit, just like what I described already, but the signs and symptoms disappear within a little longer window of time, within 24 to 72 hours. More than 72 hours, it would be classified as a CVA. Okay, and again, we're talking about ischemic events now. We're not talking about hemorrhages. We'll get there later when we get to strokes, but these are ischemic events. All right, now advancing to what might happen if you don't get the TIA properly diagnosed, and that would be a stroke or a CVA or a cerebral vascular accident. And that is a general term most commonly applied to cerebral vascular conditions that result either in ischemic lesions or hemorrhagic lesions. Now, you already know about what ischemia means, and hemorrhage, you probably know what that means too. That means where a vessel, a blood vessel, breaks and leaks blood into the surrounding tissue. So there are two kinds of CVAs, in other words, and we'll get to those. There are hemorrhagic CVAs and ischemic CVAs. Also, those are referred to as cerebral infarctions. The word infarction may be new, so we'll get to a definition of those things in the next slide or two. But before we get to those, we're just going to talk about hemorrhages first. So we're talking about a group of CVAs referred to as hemorrhagic CVAs, and basically they get divided into three groups according to the size and location. There are small vessel hemorrhages in which the area of damage to brain tissue is quite small. You can see 2 to 15 millimeters. That would be referred to as a small vessel hemorrhage. And they are intracerebral, not out here on the surface of the brain. We'll get to that. They are within the brain tissue of the cerebrum. They're intracerebral. And they are actually, we're going to look at it a little later, but the middle cerebral artery, the very first branches off of the middle cerebral artery dive into the deep areas of the cerebrum, including the thalamus, the basal ganglia, the internal capsule. It's those vessels, they're rather small. Those are the vessels that break. They're small vessels. This disease process, small vessel hemorrhages, is strongly associated with hypertension and diabetes mellitus. So when you see patients who have them, very good chance that in their medical history they have one or both of those two disorders, which are risk factors for that type of a hemorrhage. It's the disease process starts with an impregnation of the small vessel walls, the walls themselves of those tiny little arteries, with a hyaline lipid, and then cholesterol. And then the wall basically gets weakened, and you get what's called an aneurysm, which is a balloon. It's a balloon on the wall of a vessel. And if that aneurysm grows large enough, it will break, and there's your hemorrhage. Now you have blood in the brain tissue, and these are small vessels, so they tend to self-contain in a way, I could say, that how do you stop bleeding? Put pressure on it. Well, the brain tissue does serve to provide pressure on that leaking tiny vessel, and eventually they'll stop, and hopefully you don't have a very big stroke. Oftentimes people have been asymptomatic, and they finally get a bigger stroke, and they go to the hospital, and then they get their CT scan, and they'll see the evidence of these past small vessel hemorrhages. All right, now, they're found in deep areas of the cerebral hemispheres. We said that. They may be the cause of lacunar infarcts. I just want to say a word about that. You're going to see so many patients who come in with a big stroke, and they do the CT scan, and the report will say they had multiple lacunar infarcts. They're already there, in other words. So it's not the cause of the major deficits that would come from a big stroke. But it shows that there's a disease process going on. And of course, they're not good for the brain. But what is a lacunar infarct? Well, it's a little bubble where brain tissue used to be. That's the lacoon. A lacoon is just bubble. And they're referred to as lacunar infarcts, but they could actually come from the hemorrhagic process I just described, in which case they're not infarcts, as you'll see when we get to the next type of stroke. The next type of stroke is referred to, they're infarctions, and they're strokes caused by deprivation of blood supply or ischemia. So when they see these little bubbles, they don't exactly really know if they came from hemorrhages or if they came from little areas of ischemic damage caused by a blockage. Basically, a very similar kind of disease process could cause either one of them. And all they do is they see the little bubbles. They're occupied by fluid instead of brain tissue. And they are quite small. We're talking about small vessel hemorrhages or kind of jumping ahead, small vessel infarcts. All right, now in the next size, remember we're differing by size and location here. This is an intracerebral, still within the cerebral hemispheres, not on the surface of the brain, but larger. They're larger, and they can be massive. You can have a very big collection of blood, that's the size of a baseball or something. It starts to put pressure in all directions, and it can very easily be fatal. It's just a question of the size. Now we get to something which is a little different. This is a subarachnoid hemorrhage. The hemorrhage is not into the brain tissue, but into the subarachnoid space around the brain. And you can have that hemorrhage anywhere around in vessels that are on the surface of the brain, and blood will go everywhere. So if they did a lumbar puncture for such a patient, they'd find blood down there, even though the hemorrhage is probably up here. And it is caused by problems with the formation of the arteries that are actually probably present at birth. They are referred to as saccular aneurysms, baryaneurysms, and arteriovenous malformations. You can Google those if you want to look at them, but in the interest of time, I'm not going to go into the detail. But these strokes or hemorrhages, they are strokes, tend to occur in persons younger in life, usually in their 30s or 40s. They'll have strokes. Now that's kind of young to have a stroke. We usually think of strokes as being 70s and 80s. Upward from there. But these were caused by malformations of the arteriovenous system, and it just took that long for the pressure to get great enough to cause them to actually hemorrhage. In other words, if somebody had a little baryaneurysm, they may be completely asymptomatic for many, many, many years, and then one day they have a big hemorrhage into the subarachnoid space. It's very easily diagnosed with even the CT scan will show that instead of having cerebral spinal fluid out there, the density is a little bit different and indicative of blood mixed with the cerebral spinal fluid. All right, so here I covered this point that they are caused by anatomical deviations in the arterial system or the arterial and venous system, and they generally occur in the 30s or 40s. And if they're discovered before death, they can be often treated with radiotherapy, where they shoot a beam and shrink the problem, or treated surgically and the problem area removed. Sometimes very successfully, by the way. People can have a hemorrhage and be completely healed, basically, depending upon how lucky they are, I guess you could say. All right. Okay, now, while we're on the subject of hemorrhage, I just want to make reference to hemorrhages that are caused by trauma. So these would not be strokes. They're hemorrhages, but they're not strokes. They're hemorrhages caused by trauma. So where do these tend to happen? They happen usually in the subdural or the epidural space. Your dura mater has arteries coursing through it. And so if you have even a skull fracture that's not really noticeable, it can cross one of those arteries and cause it to break. And they're small. They're called meningeal arteries. They're small little arteries, but they'll start to leak fluid, and it'll form a collection in kind of a pool, either underneath the dura and between the dura and the skull, or just between the dura and the arachnoid matter beneath it. And either which way, they're contained, they start to put pressure on the brain, so they can definitely be they can definitely kill if they continue and put pressure. Then the pressure goes in all directions, even though you might have the hemorrhage over here, but it's acts like a space occupying lesion. In other words, getting bigger, 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 and pressing in all directions. And so what do you tend to have? They're non-localizing. They tend to just start getting confused. They do the CT scan. Usually there's been trauma involved. It could be an auto accident. A lot of times with kids, they fall on their bikes or something, and they'll usually, if they don't do a CT scan at the time, or even if they do and the child goes home, they'll tell the parents or caregivers to check the consciousness level, checking for confusion over a 24-hour period in case it develops slowly. They want to know about it. Okay, now we get to cerebral infarctions. And cerebral infarctions are areas of tissue necrosis. Now that's dead tissue, dead brain tissue in this case. That would be the infarct, area of dead brain tissue or tissue necrosis caused by ischemia. That's a key thing. If you have a hemorrhage can kill brain tissue too, but that is not an infarct, that's a hemorrhage. So a CVA, or I shouldn't say CVA, an infarct type of stroke is caused by ischemia. And there are two types. Actually, the brain damage itself is not different between these two types. The way the damage got done, the cause of it, in other words, is different. The first type, which is the most common type, is an atherothrombotic infarction. And that is, and what results would be called a thrombotic infarct. It's usually caused by a slow progression of a disease process, often in the carotid arteries, that starts to occlude the flow of blood through the artery. It's a very slow process that takes years and years and years to happen. And then finally, one day it's too much and the person has their infarct or their stroke. The other kind, which is less common, but still quite common, is called an embolic infarction. And that is caused usually, almost always, by a blood clot that forms in the heart, in a heart that is not working right. We'll get to that later. And that clot breaks off and flows up through the arterial system to the brain. It could go anywhere, by the way, but if it goes to the brain, it'll cause a stroke. What kind of stroke? An embolic CVA, an embolic infarction. So we'll look at the two types and how they get diagnosed. And going back to what I said a few minutes ago, regardless of which one of these two things caused it, the nature of the brain damage itself is the same. There's an infarct caused by deprivation of blood supply. Okay. Now, we want to look first at the atherothrombotic infarction, and I want to start with the process that goes on over many years. So what is the atherothrombotic infarction? If there is a gradual stenosis or narrowing of the lumen of the artery, that's the inside of the artery, the part where the blood flows through. If you have a hose at home out in your garden, it's got a lumen. It's got walls and it's got the inside where the water flows through. That's the lumen. So that gets more and more narrow as a result of this disease process. It doesn't have to be completely blocked in order for a stroke to occur, a thrombotic stroke to occur, but it has to be blocked enough that enough blood does not get to some part of the brain. So the actual degree of occlusion is variable and it's dynamic. In other words, it changes from moment to moment to moment. And we'll look at that process. But let's look at the whole thing. So what happens first is that there is a proliferation of smooth muscle cells within the walls of major arteries. Let me just start there. Now, what are these smooth muscle cells? The bigger arteries, not all of them, but bigger arteries, as for example, the common carotid artery and the internal carotid artery and arteries down to your legs and the big ones, they have smooth muscles that are within the walls themselves, and they go circumferentially, around, not longitudinally, but around. And what are they there for? They are there to regulate the flow of blood to different parts of your body for different purposes at different times. So, for example, after a big meal, you may tend to get a little drowsy. Why? Your blood is being routed to the digestive organs to do the job they're going to do, and a little bit, not quite so much to the brain. So that's the purpose of these smooth muscles. They serve a very, very important function. If you're going to run, for example, get away from danger, blood goes to your legs so that you can get enough blood to do the running. So it's a very amazing process, actually. So that's what I mean is dynamic. They're always changing. They're always contracting a little bit, let a little less blood go here and more here, or whatever. So what happens is these smooth muscles start to proliferate, meaning they multiply and they get more of them. And they start to thicken the wall a little bit because there are more of them. And like just if you do a lot of workout, you get a bigger arm or whatever. Same process is going on. There's a proliferation of the smooth muscles. I said it takes place over many, many years. There was a study in the early 50s of of soldiers who had died in the Korean War, and they did autopsies, and somebody studied the carotid arteries, and they saw that already, not everybody, but some of those people had signs of this disease process already in their 20s. Yet, typically, when you see somebody who has a thrombotic CVA, they will be older. They'll be in their 60s, 70s, 80s, could be even more. So it takes decades for this process to go on. Starts with the proliferation of the smooth muscle cells within those major arteries. And now, the proliferation will tend to occur, I'm making this point down here, at certain places more than others. It takes place at bifurcations and curves. Why? Because of the hydraulic forces involved in the flow of the blood through it. That will just put more pressure or more, I'll call it trauma, on certain places because of it. When you think about a bifurcation, if you've ever looked at a river that is swollen with water and it has a bifurcation in it, there'll tend to be erosion right there because of the water flowing quickly, less so on just the sides of the straightaway part. And same thing for a turn. If you look at a river that makes a turn, you'll see erosion on that one bank more than, again, on the straightaway part. So it's due to hydraulic forces exerted by the blood on the vessel walls. And it's highly prone to occur at the bifurcations of the common carotid artery. So we're going to refer to this carotid artery a lot. In other words, you can have the disease process all over, but this may very likely be the one that causes the problem. And you actually have more disease process here. And so this is the cause of the stroke when it finally happens. So we've got the proliferation of the smooth muscles. Then the next stage, going to occur some years later, depositing of cholesterol crystals among those proliferating muscles cells, smooth muscle cells. And so now you kind of see, y'all know, I'm sure, that blood pressure is a problem when it comes to preventing strokes. If you have high blood pressure, you're more likely to have this kind of a stroke. And also cholesterol. So two things that are done to try to prevent the development or the advancement, the speedy advancement of this disease is regulate blood pressure and regulate cholesterol. Okay, so we've got the proliferation of the smooth muscle cells within the walls and then laying down of cholesterol crystals among those smooth muscles. And here you start to see you're getting those walls are getting thicker. Now, they get thicker until one day the inner lining of the vessel, of the artery, called the endothelium, arterial endothelium, actually breaks. It's not a big deal. It's not going to cause a hemorrhage into the surrounding area, at least not for this kind of stroke, but it actually breaks. And then what happens is your blood reacts to it as if it is a wound. Now you just think about cutting yourself. What happens? You form a scab, which is a clot. It starts with a clot, then it dries up and everything. But it's the same process. Your blood is flowing through that cut on your arm or wherever it is, and it's saying, oh, there's something wrong here. Let's form a clot. Same thing happens here. The arterial endothelium finally breaks down because the walls have gotten too thick, and the blood clots at that place. Your blood platelets and fibrin form a clot. These are components that they can measure within the blood, by the way. And then ischemia of tissue in the region that is supplied by that particular artery occurs. And if the ischemia lasts long enough, and I'm going to say roughly 7 minutes, because how long does it take to deprive your blood, your brain of blood and actually drown to death? 7 minutes, typically. Longer in real cold water, but you know, it's a few minutes. And so if you have that deprivation go on, if you have the ischemic process go on long enough, 7 minutes roughly, it will form an infarct. In other words, the brain tissue cannot be recovered with the restoration of the blood supply. At that point, it's going to become necrotic. It's going to die. I prefer to use the term necrotic because that's the technical term. And if the clinical presentation of the signs and symptoms lasts for less than 24 hours, this process will be labeled a TIA. And if it goes on longer, it will be labeled a CVA. All right, now, I just want to go back and say one thing about this. How would this ischemia possibly last and then get better in less than 7 minutes? Remember, the smooth muscles are constantly doing something depending upon the exact moment and what the rest of the body is engaged in. So it's a dynamic process. The degree of stenosis in a vessel that's got this disease process, and even when it's formed a clot, it's still a dynamic process because you have the smooth muscles contracting or relaxing, depending upon the particular needs of the moment. And there are other factors too, which we'll look at in a moment. Okay. Now, let's look at the factors that determine the moment of the infarction. With a process that takes decades to go from maybe the 20s to 70s, why do you have the stroke on Tuesday, the 11th of September, as opposed to 10 years ago or 10 years from now? So what are the variables? The main variable is the atherothrombotic disease process. I think I meant to say process, but progress works. So that's the one that takes years, and I just described it. The speed of that progression of the gradual process will be determined partially by genetics. There is a genetic component. Lifestyle factors like smoking, health factors such as diabetes. Diabetes is hard on your blood vessels, and it's traumatic for the blood vessels. So you'll see in people who have infarctions, there's many of them. I don't know the exact percentage, but larger than the general population will have a history of diabetes mellitus and or hypertension. So both of those things are traumatic to the vessels. We talked about the hydraulic forces here, and diabetes is kind of a chemical, a source of trauma to the vessel walls too. Okay. Other things that are going would be the moment-to-moment variability in the diameter of the artery's lumen, and that's a function of those smooth muscles doing what they're supposed to do. Another factor is the availability of collateral blood supply via the circle of Willis. We'll actually look at that circle again. I think you've probably seen it later. Another factor is blood pressure. Now, blood pressure is a risk factor for development of atherothrombotic disease. But it's also, you also have to have a certain amount of it to keep the blood going through all your vessels, including these diseased ones. So in somebody who has an atherothrombotic process going on, they're going to try to control the blood pressure, but they don't want it to go too low because then it may not be able to get the blood through that point. So that is a variable. Your blood pressure is going up and down all the day, all the time. So they want to keep it low enough so it doesn't advance the disease process, but not so low that it can't get the blood through the diseased portion of the artery. Blood viscosity is just the thickness of your blood, and that is largely related to hydration. Like if you drink a bunch of water, you're going to be have lower viscosity, which means it can tend to get through channels, partially blocked channels better. And then another thing that it is different. It's not directly related to the thickness of your blood, is the tendency to form a clot. And that is, it's actually measured in a laboratory test called the clotting time. They come get the blood and they put it into a test tube and they actually measure the time it takes to form a clot in that tube. I don't know if you've all probably had blood drawn, but did you ever notice when they put the blood into the test tube, there's some yellow stuff at the bottom? Well, that yellow stuff is to keep the blood from clotting, because if you put blood into a space and it's not moving, it's not circulating, it's just in a tube, it will clot. The whole thing will be just one big clot pretty quick. And that how long it takes to form that clot is referred to as the clotting time. So now what they want to do is to keep the blood clotting time in a certain range so that it doesn't tend to form the clot in the disease portions of the vessel, but it's not, on the other hand, it's got to have some clotting function. Otherwise, the person they'll actually urinate blood because their clotting time is too low. So they don't want it too high, they don't want it too low, and it can be regulated with drugs, heparin and warfarin are heavy-duty drugs that they would use in the hospital. Coumadin, I'm not sure how much Coumadin is used. It's an oral drug, and it used to be used up until the last 10 years all the time. But it was hard to keep the blood clotting time in the therapeutic range. And so people who are on oral Coumadin had to go in every couple of weeks generally and have their blood clotting time measured, make sure it doesn't go too high or too low. Now, nowadays, Eliquis and Xarelto, if you watch certain channels for old people, I guess, they'll be advertising Eliquis and Xarelto. Every other commercial is Eliquis or Xarelto. The other half is Viagra or something. So these are drugs which are much easier to manage, and generally people don't have to have their blood tested at all. They just put them on this, and it keeps their blood in a therapeutic range to help them not to develop these blockages. All right. These are risk factors for the development of atheromatous disease. So smoking, the big one, hypertension for sure, diabetes for sure, obesity for sure, heavy alcohol consumption for sure. There's some evidence that a small amount, it's kind of mixed evidence, because this is all from descriptive research, which is always very messy because you can't control the variables. There's some evidence from descriptive research that a small daily consumption of alcohol may actually have a better result in terms of preventing these strokes than no alcohol at all. So it's interesting stuff, and it's a mixed bag. Lack of exercise, certainly genetic predisposition to the disease process, and other factors such as stress. There's a whole bunch of research on things. Or like, will yoga help you? This and that. It's all very difficult to interpret because it's descriptive research. In other words, you can't control people for years and years and years in order to have a control study of which one of these factors does what. But we know about these for sure. Okay, now embolic CVAs. Oh my, we're almost there. We do need to look at the anatomy of the cardiovascular system in order to fully understand embolic CVAs and to understand the reason why you only can have an embolic CVA if it forms in the left atrium of the heart. You can clot any place in the heart, but it's typically the left atrium will cause strokes. Formation in the right atrium causes another kind of problem. So I want a bad one too, by the way, but not a stroke. You won't be seeing those patients. So we just want to start by looking at the flow of blood through the heart. And the heart, the blood comes back to the heart. This would be from the veins. It comes back to the heart and it drains into the right upper chamber or right atrium via the superior vena cava. And here's an inferior vena cava. And they're trying to show here the little hole that takes the blood into the right atrium. Okay, and then from there, from the right atrium, it flows through this valve into the right ventricle. And then from there, it goes through the pulmonary arteries to the lungs, gets reoxygenated, because remember, it's been all over the body and the oxygen's used up, not all of it, but enough of it, gets reoxygenated. And then it comes back to the left atrium of the heart, goes into the left ventricle, and then it goes through this valve, that is a valve, into your aorta. And then from there, it's going to, the aorta is a trunk of a big tree. The branches go all over the body. And you know some of them because you've studied the ones that go to the head. So basically, blood comes into the right atrium, goes to the right ventricle, goes to the lungs, comes back to the left atrium, comes back to the left ventricle. And this is the problem chamber for us, where we get strokes from. And I would just want to look at the anatomy a little more. This is what you just saw in a schematic way, but this is a more realistic picture of a real heart with the ventricles and the aorta. It shows the arch of the aorta. This is the ascending aorta, the arch of the aorta, and the descending aorta, which goes down through your body cavity and divides down into both legs. And we're going to look at a little detail up here because basically we want to follow this system up to the head, particularly the brain, not so much the entire head, but to the brain. And I think it's partially a review, although I might have looked in a little more detail at the heart. All right. I want to go back and just say something about this and why is this the problem? This is the problem because if you get a clot formed here, it's going to go into the ventricle, and then it's going to go out through the aorta, and it's going to go wherever it goes, and which certainly can be the brain. Here it's the one that goes up toward the upper part of the body, including the brain. If it comes down here through the descending aorta, it will cause a problem, but it's going to be you're going to have like a stroke in your legs or something down there. Could be part of the body cavity. You can have a stroke in your intestines, for example. They don't call it a stroke, but they do call it an infarct. But we're only concerned with the ones that go to the brain, and those would form here. You can get the formation of a clot here too. And where does it go? Here to the right ventricle and then to the lungs, and it causes what is called a pulmonary, for lungs, embolism, which is life-threatening, by the way, but they don't call the SLP. I've seen those people, but only because they have, coincidentally, they also have something else, which is possibly caused a dysphagia, and then we do a swallowing eval. So I've seen them, but it's not the primary cause of what I'm seeing them for or what an SLP is seeing them for. All right, so back here, I want to point out here while we're here that we're going to start to focus up here, and I want to show that the first branch off of the aorta is this branch, goes off to the right. You don't have one on the left. It goes off to the right, and it is called the brachiocephalic. Brachial for arm. So I'm pointing the wrong arm because it's on the right. So it's going to go to my right arm and the right side of my brain. Brachiocephalic. And so it's about 3 inches long or so, and then it divides into the brachial or subclavian artery, I should say, that goes to the arm. And then this one is the common carotid, which goes to the head. Then we come back here to the aorta because we've done one branch here. And on the left side, you get the same destination points, head and arm, but note that the common carotid comes right off of the aorta. And then this right subclavian artery to the arm comes right off of the aorta. So branch number 1, brachiocephalic. Branch number 2, left common carotid. Branch number 3, left subclavian. Why there's a difference between the formation of these arteries on the right and the left, I do not know the answer to that, but I bet there's an anatomist who could answer that question if we were interested. All right. So this puts into words what I just said. We've got the ascending aorta, the arch of the aorta, and the descending aorta. First branch, brachiocephalic, and then it divides into a right common carotid and a right subclavian. And then the first branch off of the subclavian is the one you know, but it does not show it here. It will in our subsequent illustrations, but I just want to point it out while we're at it. The vertebral artery. And the vertebral arteries, basically they supply your brainstem. So we will look at those. They're very important. Okay, back to the arch of the aorta. Our second branch is the left common carotid. And the third branch is the left subclavian, and it too does have a vertebral artery that comes off of it, not shown here. All right. And this just shows the same thing I just went through with everything else taken away. So you can see here it's labeled, I'm sorry about that. Here it's labeled the innominate artery. Brachiocephalic, it's the same thing, two different names. And here we've got the left common carotid and the left subclavian. Thank goodness they have the names I've already provided. Okay, now we're going to now look a little further up to see how we get the blood up to the brain. So we've got the common carotid coming up on each side. You can note that they formed a little differently on the right versus the left, but it doesn't matter at this point. It's a great big artery coming up the more or less the front of your neck beside the trachea, right in that general region. And when it gets up to about C3 to 5, someplace in that zone, see, those are the third, fourth, or fifth cervical vertebra, or the upper border of the thyroid cartilage, right around that area, it divides. It divides into an internal carotid artery that goes to the brain, and it does actually supply most of the blood to the brain, but not the brainstem. And then the external carotid artery, here it is, which right there, it provides blood to the face and the neck regions and all the cavities. So oral cavity, nasal cavity, it's all supplied by this major vessel. And of course, it's a very important vessel. But as SLPs, I don't recall ever having to think about the external carotid artery in any significant way. I think if you worked in head and neck cancer, which I don't, that might come up more because you're dealing more with structures and stuff. But if you're just thinking about the brain, you don't have to think about the external carotid artery. All right, so we're back to the we're back to our sources here. So we've got another depiction here of the bifurcation of the common carotid into a external carotid artery, external kismes, and an internal carotid artery. And then that internal carotid is the one we're going to track up, and it just continues on up. Where's my cursor? Here's my cursor. Continues on up, and it goes through the base of the skull and a little foramen referred to as the carotid foramen. How convenient. It's named after the artery. And again, the external carotid provides blood to the face, the oral cavity, the pharynx, and the larynx. Now, this shows the vertebral artery. So remember I said that on both sides it does come off of the subclavian artery, and here we see this was the right, so there's a brachiocephalic. Here's the subclavian, but it would look the same on the other side. It would just, its origin is a little different. And here we have the vertebral artery coming up and coursing through the transverse foramina, little hole in the transverse process of C1 through C6. And that provides some protection for it. It's protective in function. And it is, by the way, it's too deep to feel. So you can palpate the common carotid and even the internal carotid artery. You can feel way up here, and I'm well above my thyroid cartilage, and I can feel it. I can feel it pulsing. Not the vertebral, however, it's too deep. So it just courses upward through those transverse foramina of C1 through C6, and then it gets up to the base of the skull, and it enters, one from each side, through the foramen magnum. That's the foramen through which your spinal cord goes. So below the foramen magnum, spinal cord. Above the foramen magnum, medulla. So that's that. We've got all the blood now for the brain up into the cranium when we get to that point. And now we can go to this illustration, which hopefully is, you're pretty familiar with it, because what we're going to look here at is we're going to look at the internal, and we're going to look at the internal carotid artery, the two of them. There are two of them, obviously, and the two vertebral arteries, and how they link up into a circle of Willis. All right, so we want to join our vertebral arteries with the carotid artery. So let's look at the internal carotid artery. It branches. Here it is. Now, what is that? That's the cut artery. Where is it cut? Right as it enters into the cranium. Goes through that carotid foramen. That's where the cut is, and so they've cut it there. Then they've cut down here, right as it enters through the foramen magnum, those two vertebral arteries, and then they can lift the whole brain out and we can look at it. So what we see is we see a middle cerebral artery and we see an anterior cerebral artery. In other words, the internal carotid artery branches into the middle cerebral artery here and the anterior cerebral artery here. Now you can't see much of the anterior cerebral artery. And if you go over to this side of the brain, you can't even see the middle cerebral artery. Why? Because the temporal lobe is covering it up. Over here on your left, my left, the anterior pole of the temporal lobe has been cut and removed so that we can see that middle cerebral artery coursing outward through the sylvian fissure until it gets to the side of the brain and then branching off into something that supplies a big territory of the brain. I want to point out one more detail, and then we're going to have to, we're going to have to look at different views in order to see this whole system. But I want to point right here to this little artery that connects the two anterior cerebral arteries, and that is referred to as the anterior communicating artery. So we partially formed a circle of Willis at this point, but it needs also to be linked up to the vertebral artery system. And down here, go back here, we have cut ends of two vertebral arteries. Where were they cut? As they course through the foramen magnum. And they course up more or less through the ventral surface of the medulla, or along the surface. It's not, in other words, they're not in the medulla, they're on the medulla, the ventral surface of the medulla. These two vertebral arteries course upward until they get to the pons, and then they form a single artery known as the basilar artery. So the basilar artery is formed by joining the vertebral arteries at the junction of the medulla and the pons. And then that basilar artery divides into two posterior cerebral arteries right here. Here is one, here's the other one. And they have cut, this is the cerebellum, this is the brain, this is the medulla, this is the pons. We can see a little bit of the midbrain here. And they have cut away part of the cerebellum on our left so that you can see the territory of the posterior cerebral artery, more or less the back of the cerebrum. And then to complete the circle, those two posterior cerebral arteries are joining the internal carotid right here with these posterior communicating arteries. So we have a completed circle. This is a schematic. It shows exactly what I just went through, but the brain's gone now. We can see the two vertebrals, the basilar, the two posterior cerebrals, the two posterior communicating, the internal carotid, the middle cerebral, the anterior cerebral, and the anterior communicating. Now, I didn't mention these little arteries coming off of the basilar, but those arteries, and they're little arteries that come off of the vertebral arteries too, and they're not even shown here. And we can see them when we go back here. No, see? Little arteries supplying the pons, the cerebellum, and the medulla. In other words, the brainstem and the cerebellum all come from the vertebral basilar system. Your brainstem gets its blood from the vertebral basilar system. So when you have a stroke involving the brainstem, it's something going wrong here. All right. Now, we're going to do a little more detail than we do for the rest of the arteries when we get to the middle cerebral artery, because it feeds the areas that are sort of the focus of this course, the language zones, and so we need to look at some detail. So here is a middle cerebral artery. What does that make this? This is an internal carotid artery. What is this? This is an anterior cerebral artery. Here is an anterior communicating artery. The section is a totally different view from what we've looked at so far. This is a coronal section made right through the brain, separating front from back, right where the formation of the middle cerebral artery occurs, and where it courses out through the sylvian fissure. Now here's the sylvian fissure, but note, as it courses through this brain tissue, it's throwing off these little arteries that go to very critical areas for SLPs. The basal ganglia, the thalamus. Here's the thalamus. Here's the basal ganglia. And this thing, the internal capsule. This is the internal capsule. We mentioned the internal capsule a lot because all of your ascending sensory pathways for somatosensory functions, pain and temperature, fine touch and proprioception, and for vision, they all go through that internal capsule upward toward their particular area of the cortex, whether it's the postcentral gyrus or the primary visual receiving area back in Brodmann's area 17. And all of your pyramidal tract neurons and your extrapyramidal tract neurons, the upper ones, come down through the internal capsule. So when you get strokes that involve the middle cerebral artery, you have a potential for a lot of very bad deficits. Out here we have, if you're on the left side of the brain, the language zone, so you can get an aphasia and then a right hemiparesis because you've got those descending motor pathways coming down here, crossing at the caudal medulla and going to the other side of the body. And then you have your ascending sensory pathways trying to get up here. So the first major branches off of the MCA, I'll use that abbreviation for convenience sake, are referred to as the lenticulostriate arteries, right here. And they are going to provide blood to the thalamus, the basal ganglia, and the internal capsule. The next major branches of the MCA supply blood to what I'm going to refer to as the lateral convexity of the cerebrum, the side of the brain. All right. This shows the territory provided by with blood by your three cerebral arteries. Looking at the left image first, you can see that almost the entire side of the brain, the lateral convexity, is supplied with blood. It's shown pink here, and that's supplied with blood by the middle cerebral artery. So you'll go back here. This is supplying blood to all that's pink. You see there's a little pink there, but not much. Then up at the top, and then if you cut the brain in half and divide it in two halves, you can then see the area that is supplied with blood by the anterior cerebral artery. Here's in blue. So a little bit here we can see up the top of the brain, but a lot here, including the precentral gyrus right here, and the postcentral gyrus right here. And that would be the part that's subserving the lower extremity. So remember the motor homunculus? The foot of the motor homunculus is dipping down into the mid-sagittal fissure right in here. So if you get a stroke involving the anterior cerebral artery, could you have such a stroke? Absolutely. Will the SLP see them? No. The physical therapist will, but they won't have any language problems, and they won't have any cognitive problems. They're going to have a problem with weakness or loss of sensation of the lower extremity. And then the posterior cerebral artery provides blood to everything that's yellow here. And this is including the primary visual receiving area and the secondary visual receiving area. So people who have strokes here will have a contralateral loss of a visual field. Not so much language and speech, though. All right. So now you know the route. So what we want to talk about now is a little more about the formation of these emboli that are going to follow a route. And remember, once the clot forms, it's going to go where the blood supply goes. It could go kind of a lot of different places, but if it forms on the left side of the heart, it can go to the brain. It's just by chance that it does, or it might come down. But if it forms on the right side of the heart, it's going to go to the lungs, going to be filtered by the lungs, and it's going to cause a pulmonary embolism. So most emboli that cause an embolic CVA originate in the left atrium of a heart that is in atrial fibrillation. And what is that? Atrial fibrillation is a status of the heart when the heart isn't really beating. And I shouldn't say the heart, because the ventricles are beating, but the atria are not. So all four chambers of your heart beat with a thrust that pushes the blood through the valve into the next chamber or out through one of the vessels or to the lungs. So you need that contraction to push the blood. If a heart atrium is fibrillating, it's not really contracting, it's just vibrating. It's going like this. Now, how does it even function? Your atria can fibrillate and the blood will still go to the lungs because the right the right ventricle is pumping. So the ventricle pumps, but the atrium doesn't. And so that means that the blood is going to go through the heart, and it's going to go through the heart as well as the ventricles make it go through the heart, but it's not going to make its transition through the atrium very as well. And it's going to tend to not circulate all of the blood in the atrium out through the valve into the next segment of the system with force. And that allows blood then in the atrium to do what happens in the test tube. Basically, it's not moving enough. It is moving, but not enough to prevent the formation of clots. So people, if they're having atrial fibrillation, they generally will say if you have it for longer than 24 hours, it's kind of a crisis and it needs to be managed in some way. We'll talk about the management later. You can also get the formation of an embolus in a diseased heart valve that is not allowing blood to go through it in an efficient manner and allows the formation of a clot. So that does happen less and less, actually, because one of the most common sources of a diseased heart valve is rheumatic fever. And you probably or possibly have never heard of it because it's now managed very well with antibiotics. It used to be, and I actually had rheumatic fever when I was a kid. I got strep throat a number of times, and one of them became rheumatic fever. And then they had just started, I'm pretty old, they had just started penicillin. And so I went on penicillin after that for many years to prevent the formation of these infections and just keep it from happening again. And eventually my heart valves seemed to heal themselves because the physician could hear it as a heart murmur. You probably heard of a heart murmur. And then after 10 years or so, couldn't hear the heart murmur any longer. And the conclusion was that I was okay and I didn't have to be on penicillin anymore. But that for that age group, for older people, rheumatic fever was a very common cause of damaged heart valves, which then could form a clot. And I don't remember seeing anyone like that very recently, but I certainly have seen them. And then if you go to some parts of the world where infection isn't quite so well controlled, you certainly might see it. So let's see, we've done this. A small number of emboli can form around a damaged heart valve. And if it forms in the left atrium, you can get a stroke. If it forms in the right atrium, pulmonary embolism. So regardless of which way it forms, any embolus that originates in the right chamber of the heart will travel to the lungs and cause a pulmonary embolism, not a stroke. We went over that already. And a small number of embolic CVAs are caused by a thrombus. Oh, this is kind of a minor point. You know the thrombotic process we talked about, especially in the carotid artery, that little clot can break off and go upstream and form an embolic CVA. But here's the reality, and here's the reason why it's a very minor point. When they do the tests, they will determine that the heart is pumping well, and then they'll see with a test that the carotid artery has this blockage, partial blockage in it, and they will then assume it's an atheromatous disease process, and they will treat it as such, which actually works out because the treatment would be the same, prevent the formation of a clot. But that's just a kind of a minor point which you can forget about if you want to. Okay, what are the frequencies of the different types of CVA? The ischemic CVAs, the infarcts, whether they're caused by atheromatous process or embolic process, it's about 80% of all CVAs. What are the rest? 15% hemorrhagic, we'll subdivide a little bit here in a moment, and 5% unspecified. What does that mean? It means they didn't figure it out. And so 5% of the people couldn't be put into a particular category. And by the way, I should have a citation here so you know where I got it. And I neglected to put that in. And if you look this up, you would find a number of studies. There are descriptive studies, it's follow a bunch of CVA patients and figure out the percentages that had these different specific etiologies. So if we look at the 80% who had the ischemic strokes, the infarctions, most of those were atherothrombotic and a smaller number were embolic. If we looked at the hemorrhages, most of them are 80% of most of them are 80% of them anyway. And remember, hemorrhagic less frequent, but of that number, 80% are intracerebral and 20% are subarachnoid. Those are the ones that develop from the malformations and tend to be in younger people when they finally have the stroke. Here is the medical diagnostic process. First of all, history and physical, it's always the same. And the telling things that would show up when that person gets to the ER and they test them is they're going to see a localizing sign, and they're going to hear about an onset that was rapid, relatively rapid over the course of, it could be a few minutes or a few hours, but not very, very, very long. And then they are going to do they're going to do a CT scan. Now they'll of course listen to the heart, and if they don't hear atrial fibrillation, may not go that direction in the diagnostic process. But they're going to do a CT scan, and they're going to do it very rapidly, because one of the things that CT scan could show is that they not only have a hemorrhage, but it's an ongoing process and could be very dangerous, and so they want to diagnose that very quickly. They're almost always localizing and kind of show the direction of where the damage is occurring. Keep in mind that an intracerebral hemorrhage can show non-localizing signs because it's putting pressure as it grows in all directions. And the computerized tomography, you all know what CT scans are. They will show hemorrhage right away. So if the hemorrhage is present, the diagnostic process is pretty much over. They know what it is. Anyway, but it will not show an infarct for several days. And the reason for that is the CT scan is basically analyzing the density of whatever it's going through, the tissue it's going through or the fluid it's going through. And as when that infarct is formed, the density of the brain tissue is still the same. And so it just won't show up. But as the necrotic process goes on, remember it was deprived of blood long enough for it to become necrotic, to die, and then that tissue starts to break down, and eventually the area that was deprived of its blood supply, the area of infarct, will be replaced with a fluid-filled space, and that will clearly show up. And even before it gets to the fluid-filled space, it breaks down enough to start to show an area of lightness in the coloration pattern, and the infarct can be diagnosed then. But of course, they can't tell by looking at the infarct if it's caused by an embolism or a thrombotic process. And the CT scan can also rule out tumor, which usually has a little different history. Tumor usually will show a gradual onset of signs and symptoms. Occasionally, there'll be a rapid because it just got to some certain location and caused enough pressure to show signs and symptoms today, but they weren't there yesterday, type of thing. But usually it's gradual onset. Other things with an EKG, where they've studied the electrical pattern of the heart. Most of you have not ever had one, but they put those little things that attach wires all over your chest, and then they look at the speed and rhythm of the beating. They can identify disorders of rhythm, speed, intensity, and organization of cardiac responses. They can also show myocardial infarction, a heart attack. And and it's a very easy test. Every ER has more than one EKG machine around, I'm sure. So they'll do that right away. Unless they see no evidence for it, they may not do it on every single patient. I'm not quite sure about that, but it's an easy test. It's an inexpensive test, and that will be very common. And then less common will be this thing called an echocardiogram, which can identify valve disease. Remember, we talked about that as a less frequent source of embolism, and the frequency is diminishing as we grow in time and away from causes like rheumatic fever. But sometimes they'll do that if they can't find it. If they don't see a hemorrhage, because if you see a hemorrhage, you're kind of done with the process. If they don't see a hemorrhage and they don't see an infarct because it hasn't been several days, and the heart is beating fine, maybe they hear a murmur, maybe they don't, but they can always do an echocardiogram to see the anatomical integrity of the heart valves. All right. Now, here's a really common test. They're probably not going to do it if they see a hemorrhage because the diagnostic process is over. But if they don't, the diagnostic process is not over, and they will want to know how's the flow of blood through the carotid arteries. And so this is a non-invasive test. It's not dangerous. It uses ultrasound, and they just scan the arteries only in the neck, though. They can't go through bone. It only goes through soft tissue, and it will show the percentage of normal flow that is going through the common carotid, the external carotid, and the internal carotid. Mostly we're interested in the common carotid and the internal carotid, but it'll show that. And so they look right around the bifurcation, and that is, in fact, where the disease process tends to form. Again, it doesn't mean that all the other vessels are perfectly healthy and it's all just here, but this is the problem area where you tend to get the blockages, because they're big vessels, they're important vessels, and they're subjected to a lot of hydraulic forces. Sometimes they'll completely rule out significant stenosis. Now, you'll read, it's a simple little one-page report that's left in the medical chart, whether it's electronic or paper, usually electronic now, and you can look that up. And here's sort of the rule. Intervention of some sort is required if there's greater than a 50% stenosis in a symptomatic patient. You see, so somebody comes in with localizing signs and symptoms, that's a symptomatic patient. Let's say they have a right hemiparesis. That's a sign, right loss of sensation on the right side of the body. That's a symptom. And then they show 50% or more stenosis of either the common carotid or the internal carotid on the left. That's a situation which they're going to want to take care of that, or attend to it anyway. But there are a lot of times people go for just screening of the carotid arteries, and generally they would be asymptomatic people. You know, you show up at the health fair and they can screen you for free, or screen you for $20 or something like that. And for those people who do not have signs and symptoms, it would require a larger amount of stenosis to warrant aggressive treatment. So just pay attention to the numbers. And the main reason I'm showing you the numbers right now is to realize that, especially in older people, they're generally going to have a little bit of stenosis around this area. How much is too much? Well, 50% or more in a symptomatic patient where the symptoms correlate with the location of the stenosis, and 80% or more of the for the people who have no symptoms and probably have just been screened for whatever reason. And when you get to see the treatments that are done, you'll understand why you don't want to just treat people who have a little bit of stenosis, 20%, let's say, but they haven't had a stroke and they don't have any symptoms. All right. Oh, then there's this test I want you to know about, but it's very rarely, it's not used very often, and it's called cerebral angiography. And it basically can look at and identify occlusion or stenosis in the entire system that we've talked about, all the circulation to the brain. It can identify the exact location and degree of stenosis of any of them. It can also see how much collateral flow there is, like through the circle of Willis. So this test it's an X-ray test, and what they do is inject through the femoral artery down here. Well, they don't inject. They put a catheter up, snake it up from the groin all the way up to the arch of the aorta, and then using what we do our swallowing tests with, fluoroscopy, they can see that little catheter, and they'll snake it around and get it up into the left common carotid. They can do the left vertebral, the right common. They can look at them all individually, one by one. And when they get the tip of the catheter into the right the base of the right artery, they inject a dye, which shows up on an X-ray. And then they'll take a series of regular head X-rays, which clearly show the pattern. They don't see the movement, but they can see the progression of the dye over the course of 15, 20 seconds, something like that, and see where if there are any blockages. And this, because we've got CT scans and carotid Doppler scans, you're not going to see this very often, except if they might be planning an aggressive treatment, such as what you're going to see in the next few slides, surgical treatment or the placement of a stent. What they do then is they do the test. They already kind of know it's there because they saw it on a carotid Doppler scan, for example. They did the test, they see it, and they're going to say, we might want to put a stent in. Let's do the cerebral angiography, and then we'll put the stent in right then if it's warranted. Okay, so that's how it's used. It's used in preparation for a very, I'll just call it an aggressive treatment. I don't mean that judgmentally in any way, but it's you don't just do one of these things because they do have a risk factor. By the way, just as a kind of a funny little story, my first employer, Elizabeth Wallace, who was a wonderful, wonderful SLP, and she actually got me interested in the field. Back in the days, which was more than 50 years ago, back in those days, they didn't have carotid Doppler scans and they didn't have CT scans. So you really couldn't see in there, except they did have angiography. But they have reduced the risk factor greatly in subsequent years for this particular procedure. But at that time, it had about a 3% mortality rate. In other words, you don't just want to do it at the health fair because it's you can really encounter some problems. So you only did it if there was a very, very good medical reason to do it. And she had no signs and symptoms, so she did not have a medical reason. But she got so, seeing all these stroke patients, she got so scared about having a stroke that she got her neurologist friend, finally, after a lot of persuasion, to do one. And she was fine. But it's not a test you just do casually, only in preparation for a significant treatment. Okay, so what are the treatment options? For hemorrhages, they want to reduce the blood pressure so it doesn't bleed anymore, and they want to do surgery for arteriovenous malformations, the aneurysms, and they also will do it for the evacuation of a really large intracerebral hemorrhage that is going to kill. For infarctions, there is something called tissue plasminogen activator, or they just call it TPA, and it's known in relaxed language as a clot buster. And so for somebody who develops either an embolic CVA or an atherothrombotic CVA, they can bust the clot if given TPA, but it's got to be given within 3 hours of onset. Another reason you don't have a TIA and wait around to see what happens. You go to the hospital. So I've seen patients who, had a significant aphasia and a right hemiparesis, and the next morning they don't have it. And why did I see them so early? Swallowing evaluation. So they can be completely reversed with TPA. And so that's a very, very important treatment to be done, not for hemorrhage, because for the hemorrhage, it's exactly the wrong thing to do. It's the opposite of it'll have the exact opposite effect. And the reason it's got to be done within 3 hours is that if somebody has had an infarction, either atherothrombotic infarction or embolic infarction, either one, the tissue is going to start to break down. And if it breaks down enough, what can happen is that the blood vessels going through that tissue area will start to hemorrhage. So now you have an infarction and a hemorrhage added onto it, which is not a good thing. So it's got to be done within 3 hours, which as long as you go to the ER, your loved one goes to an ER right away, that's why they're going to do the CT scan right away. They're going to get moving. It's not the kind of patient who sits out in the ER waiting room all day long. Like if you go with a runny nose, that's what happens. But these patients they move them right through because they know the implications of diagnosing it enough to know it's not a hemorrhage and it is an infarct, and they can do the TPA. Okay, now quite a bit less aggressive is aspirin for large infarcts, just to thin the blood down a little bit. and to prevent additional infarcts is basically what they're doing. Or now, more and more nowadays, they would use some of the drugs that I mentioned earlier, the Eliquis, the Xarelto. Xarelto is not right. I got that one wrong, but on that one slide. Let's just go back and find it. Sorry about that, but I don't want to say Xarelto because I think that's not right. Was it here? I'm sorry, I can't find it now. Oh. Well, okay, so suffice it to say, the drugs that prevent clotting, heparin and warfarin are the big ones that will be used in the hospital, and they have a very rapid effect, immediate effect. So they'll use that, but that's not the kind of thing you do at home. They're actually given IVs, intravenously. So after people go home, they can take the blood thinners like Eliquis is the one to prevent it from happening again. Okay. Now, here are some additional treatment options. There's something called a carotid angioplasty, where a balloon is snaked up to the disease area, and it's inflated temporarily to reduce the occlusion, and then the whole thing is removed. The balloon is removed. Or stenting, kind of the same process. They snake up with a catheter, something that is left behind and expands to open it up a little bit. And I've got nice pictures of both of those. So angioplasty compresses the atheromatous plaque. Okay, and I have illustrations of both of them. Let me just skip ahead to those. Here is a catheter coming up through, looks like probably a common carotid and an internal carotid. Here's the plaque, here's the balloon, and here you can say, oh, here's the filter. Why do they have a filter there? Because they don't want any of this clot formation to break off and go up and cause a stroke. So it's got a little filter on it. And now they're going to inflate the balloon. Here it is. And they inflate enough to open that up. So that is referred to as angioplasty. And then the next one, here again, you have a catheter and you have a filter. And here is something that is kind of like a net that's spring-like and can expand. So they release it and expand it, and it pushes the wall out. And then of course, they pull the catheter out. All right, so these are the two tests. These are the two treatments that would be done immediately after angioplasty. So they want to identify exactly where it is, the disease process is, and the degree of it, and then treat it with one of these. Okay, alternative treatment would be a surgical treatment called a carotid endarterectomy. And this is most appropriately done when a person has the disease process we're talking about, but they haven't had a completed stroke. They've had a TIA. Or they had the disease on both sides and they did get a stroke on one side. They don't want them to have it on the other. They'll do the endarterectomy on the side that hasn't had the stroke yet, but may. Make sense? Okay, and then, so in other words, after you've had a stroke, to do an endarterectomy of the vessel that feeds that area is not going to be in a solution, but it's used for prevention. And oh, by the way, there is a little 6-minute video here you can watch if you wish to. You don't have to. And we're almost done. I think we have 2 or 3 more slides. We're going to look at intracranial neoplasms. Neoplasm means new tissue. These would be the tumors and the cancers. Here are the most frequent ones: glioma, meningioma, pituitary adenoma, neuronoma, and metastatic carcinoma that came from some other place like the lungs and spread to the brain. And the way these get diagnosed is, again, starts with the history and physical, and typically there would be localizing signs, and the onset of signs and symptoms would be gradual. That's a key thing. And a computer tomography often, very often, will be able to identify that. If not, because some tumors don't show up well, MRIs, which is a different kind of scanning technique, will show up many more of them. They can biopsy it by passing a little needle through the skull and into the tumor and take a little bit of the tissue out and study it to see exactly what it is. Why is that important? To know the prognosis and are they likely to benefit from surgery or some other kind of treatment. Sometimes lab studies of the blood can be diagnostic. And then I like this book a lot. Now, the reason I like this book a lot is because I don't see a lot of patients with head and neck cancer. But once in a while, one will come in to just the general hospital. Now, if they're going to, if it's been diagnosed, hopefully they end up at a place like City of Hope. And the City of Hope does have SLPs, and that's all they do is head and neck cancer. So they know their stuff better than I do. I don't see many patients with head and neck cancer, but I am called upon to do swallowing evaluations of patients who are admitted to this hospital or that hospital, and they need a swallowing eval, and they've got this particular etiology that comes in this category. And before I write my report, I want to have some kind of a notion of the prognosis. And these are things that I don't know a lot about. So I really like this book because it is updated every single year. And you will find I've never found a disease that's not in there. It's a big, thick book with thin pages, or you can get it electronically too. I have it on my iPad. And so you can look up the disease and or the tumor or the cancer in this case, within about 2 to 3 pages, you have everything you need to know as an SLP about prognosis. Not that say you always know what the prognosis exactly is, but I want to avoid writing a diagnostic report, which everybody in the healthcare team knows is not appropriate because I have no clue about the prognosis of this particular patient. So at least it gets me started. Now, I could talk to the doctor too, that'd be a good thing to do, but sometimes you can't, you can't go home and say, I'm gonna talk to the doctor tomorrow and then write my report. You're gonna write it right there. Because remember, it's an acute patient and they can't give them anything to eat or drink until you finish your evaluation, and including a prognostic statement and a treatment plan. How are you going to manage it? And so I really like this book. And that's why I think that's my last slide, because I don't go into a lot of stuff. There might be one more, but we're almost there. I don't go into a lot of stuff in this area because in terms of this lecture, because basically they're low frequency. Unless you work in City of Hope, then it's high frequency, head and neck cancer. But if you're in any other medical environment, they're lower frequency. You won't see too many in any one category, and it's a constantly changing area. So I like the book a lot. Okay, what are the treatments for intracranial neoplasms depending upon the nature of the disease? Surgery, radiation, chemotherapy, combinations of the above. Some people have deficits that are manageable in a rehab setting, and sometimes palliative, basically for comfort and for hospice. Now, I do have a couple more slides. Non-viral infections are these: bacterial meningitis, bacterial encephalitis, brain abscesses, tubercular meningitis, neural syphilis, and infection by protozoa and worms. That's the one I wanted to surprise you with. Will you ever see these patients in an acute care hospital? Yes, but low frequency. Again, I'd refer to the book, Current Medical Diagnosis and Treatment, when you get one, so that you kind of have an idea about the prognosis and the way that the team is going to go about managing it. These are infections, okay, obviously, and they're not viruses. A worm is not a virus. This is an article, and you think, well, how often does this happen? Millions of people in the world have worms in their brains, and not too many around in the United States, but it does happen. This was an article I read in the New York Times just last month, so this is new, and this is the worm that they found in this woman's brain after about a 6-month process of trying to figure out what was wrong with her it's just a 2-page article, and I think I posted it. If I didn't, I'll put it in the module so you can read the 2-page article if you wish to. You don't have to. But they had a very tough diagnostic time. And then finally, she started getting enough neurological signs and symptoms. At first, they were kind of like nausea and diarrhea and stuff like that. But after a few months, she started getting neurologic signs and symptoms, and they end up doing neurosurgery. And as they're poking around, they find this 3-inch worm. All right. And then here's the diagnosis and treatment. Again, history and physical, CT scan, MRI scan, lab studies to look at the cerebral spinal fluid. There can be pharmacological treatment, surgical treatments, palliative measures, rehabilitation. It's all in the book. And here are the viral infections. Polio. Polio is a viral infection of the neurologic system, affects a certain part. Herpes, herpes zoster, viral meningitis, viral encephalitis, rabies, AIDS. Diagnosis and treatment, you'll see always history and physical, CT and MRI, lab studies, pharmacological treatment, palliative measures and hospice, and sometimes rehab is appropriate. You could kind of figure that out from your book, because you'll see some have much better prognoses than others. And I've gone very fast over these, simply so you're aware that you could get a patient in one of those categories, but they will be lower frequency. Certainly way lower frequency than strokes and head trauma we're going to go to. Next week, thank goodness, that is the end. And so I will see you in class, and we'll add to it. The next lecture is going to be much, much shorter. And then I do have, and this would be for the following week, the lecture, just continuing with head trauma, etc., will be quite a bit shorter than what we just did. And then I'm going to give a lecture which only has a few slides in it, actually in class. I'm not going to record it because it's not something you're going to need to go over and over or study from. But it leads us up to actually writing the sections of reports that is relevant for what we've just gone through. The background section again, and the prior level of function section. All right, so that is it. I'll stop sharing my screen and I'll turn my recording off, and I will see you later.